And the lady, the 65 years old, she came to get the consultation for the upper eyelid blepharoplasty. She had a problem with excessive skin wedging down and blocking the superior visual field. And beyond that, they have the second problem, which you got the retinal surgery and the cataract surgery for 10 years ago. And you have the tearing, dry eye, and eye irritation off and on the left side. This is the picture show the microscopic view of the left eye on the corneal-scleral junction. We can see that they have the 5 spots, 1, 2, 3, 4, 5 of the area of the exposure of the suture material we call 10O nylon. And years by years that the suture have been sutured, and the previous surgeon did not remove the suture, so many years later the suture have been absorbed partially, and getting torn, and the stump of the suture explode from the cornea and the sclera. And every time that the patient blink and close the eye, and the suture wrap to the inside of the eyelid, we call palpable conjunctiva, and that create the keratopathy and the chronic inflammation. I will show this is the left cornea. They have the significant dry spot and then inflammation. And when we check inside, this is the left side. This is the left side is so red, and the right side is so pink and more whitish. And you can see that on the left side is so red and a lot of irritation. And next step, I will show you about how to remove the exported suture properly. I let the patient lie down and put the numbing drops, and we put the wire for let her open the eye easily. And then I let the patient look down, and I use a microscopic approach because the bare eye gonna be very difficult to see. The good technique, I show you that this is the tooth forceps number 0.12. It's gonna be so small, but the forceps with the tooth is gonna be difficult. So it would be larger. I would rather to use the McPherson forceps. It's a fine and delicate forceps that's good for grab the very tiny suture. Number one, exported suture have been removed successfully. And the next one, I'm gonna try to remove and show, compare on the Q-tip of the Q-tip. We can see the partial part of the residual suture that have been removed with the notch in the middle. And I will show on the second one, and on the position this one, I use the McPherson with the tip down, and I use a really tip that really delicate and grab. And the technique is we need to grab in one time tightly and pull with the constant force that pulling backwards. So if we grab inappropriately, and sometimes it's getting loose, and the suture has been torn, and sometimes we could not remove 100% of the residual suture, and that's gonna be another stump that could be rubbed again, and gonna be very difficult for removal on the second step. So it's a good idea to try to remove on the first time that you grab, and grab it's very tight, and retrograde, pull it back backward slowly, and then let the residual suture and the knot come out easily. In this position, it'll be a little bit difficult, so I need to rotate my microscope a little bit, and then in the better position that my right hand can be grabbed properly to the suture, can remove the suture properly. I will backward again and show you the step that grab tight and pull back, and then we can get the successfully removal of the suture material. So by this one, gonna allow the patient to be ready for no more exposure suture. And I put the drop for 1 or 2 weeks, and then schedule the patient for the next upper eyelid blepharoplasty. So it's very important to remove the exposed suture, because if we don't remove it, the patient gonna feel irritation, dryness, red eye, and chronic rubbing for the rest of her life. Thank you very much for joining my video. Thank you. Bye bye.